Okay, we're going to now begin talking about traumatic brain injuries, TBIs, traumatic brain injuries. And also in this, we will talk about our Glasgow Coma scale, and also finally then the condition of autonomic dysreflexia. All of these are very important to understand, especially you will expect to have questions like this on your NCLEX exam. I've had several students return and tell me that they had questions specifically on autonomic dysreflexia. So let's get going here. And the initial slide shows you a picture of a brain injury. This is specific type of brain injury is called contra-coup brain injury. It is one type of traumatic brain injury. There are several others, but this is the example that we're going to use. The most common cause or etiology for contra-coup brain injuries are falls and vehicular accidents, which you see in this picture. These injuries predominate in males of younger ages. Okay. A contra-coup brain injury involves a contusion remote from and classically opposite to the actual site of impact to the head. Contre-coup is a French term and it means counter blow. So the initial blow is called the coup, and the counter blow is referred to as the contre-coup. Contra-coup injuries classically occur when the moving head, the brain, strikes a stationary object, whereas a coup injury is associated with a moving object impacting a stationary head. Classic evidence of both coup and contra-coup injury is an intracerebral hemorrhage or contusion in a focal area noted on the CAT scan or MRI. The essential factors in contra-coup injury are an impact on the head and some form of acceleration, deceleration, rotational stress, or angular stress. Several of these factors are necessary to cause the contra-coup injury. Traumatic brain injury may cause multiple neurological deficits, some of which may be permanent. And of course, patient education and family education, they need to be aware of the possible life-changing nature of these injuries. As we said, some patients have long neuropsychological problems that have to be addressed even after the acute phase is over. Traumatic brain injury patients require a thorough general trauma evaluation. All patients should be managed with the advanced trauma life support measures. A detailed neurological exam is mandatory. A head CAT scan is performed for the initial assessment of brain injury. Cervical x-rays or cervical CAT scan must be performed to exclude associated cervical fractures, as most injuries are secondary to falls and accidents. Okay. What this slide wants you to know, and you can see in the picture, the importance of having x-rays. So we can see the fracture across the orbit here. A periorbital fracture is that dark line that you see on the left side of the x-ray. That yes, there is skull fracture, and that may be the primary brain injury occurs, but we also have to remember that there is secondary brain injury. Okay, So the primary brain injury is due to a sudden distortion of the brain tissue within the rigid skull. So it's very important to, we would prefer not having to treat a person with traumatic brain injury and instead focus on prevention and protective devices. What we're referring to here is the use of helmets, for example, helmets when riding your bicycle or motorcycles, and also seat belts as well. So it's always about protective devices to prevent brain injury from occurring. But there is secondary injury. And when we talk about secondary brain injury, we're talking about the low blood pressure, the hypotension, and resulting hypoxia to the brain tissue. We're talking about the swelling that occurs within the brain, compressing the brain tissue. And we're also referring to those hematomas that can develop as a result of traumatic injury. Traumatic brain injuries are associated with bleeds such as a subdural hematoma, epidural hematoma, and subarachnoid hemorrhages as well. Okay, and we learned about those yesterday. So understand that this all comes together. Hematomas can also cause compression of the brain tissue as that mass enlarges or as the bleeding continues. Treatment of brain injury depends on the severity of the injury. While the neurosurgeon is almost always involved in the care of patients with traumatic brain injury, it's important to consult with an interprofessional team of specialists, and that include a trauma surgeon, a critical care specialist, but also the nurses are vital members of the interprofessional group, as they will monitor the patient's vital signs, their neurological status, intracranial pressure, and assist with the education of the patient and family. The most common classification system for traumatic brain injury severity is based on the Glasgow Coma scale. And this score is determined at the time of injury. It is a practical, a neurological scale or scoring system that helps to assess subtle changes in the level of consciousness of patients and the overall status of their central nervous system. There are three major areas of examination in the Glasgow Coma scale. They are eye-opening, verbal response, and motor response. We add up those three scores. The cumulative score of those three areas of the exam are the result or the score, the Glasgow Coma score. Eye-opening is graded on a scale of 1 to 4. Verbal response is graded on a scale of 1 to 5, and a motor response from 1 to 6. So we can kind of use that EVM to help us remember eye, verbal, motor, and the number of maximum points in each of those areas, 4, 5, and 6. So that means that the best score you could get would be the Glasgow Coma score of 15, which is normal. Okay. The highest possible score is 15, and that individual is normal. Okay. The Glasgow Coma scale, while not a perfect scoring system, is useful in predicting the outcome of severe head injuries. And we'll return and talk more about that later. Now, unfortunately, it's an easy scale to use, but you must memorize this because you will have nursing questions asking you to score a patient on the Glasgow Coma scale, and the Glasgow Coma scale will not be provided to you. So you will have to memorize this and know how to interpret it accurately to get the questions correct. So this is very handy. This is a really nice scale. There's many scales out there, but some of them can be confusing to students. So I purposely selected this one so that you would not get confused. And so we're going to go through them, each of these three main categories here. We're going to go through them and make sure you know how to interpret them correctly. Okay. Now, I'll save that for the next slide. You can see here that the worst score you can get on the scale is a 3, because that means that the patient is totally unresponsive. For example, let's look at the scale for eye opening. They do not open their eyes. There's no response. They get a 1. They have no verbal response. They get a 1. They have no motor response. They get a 1. So the minimum score is a 3, and of course 15 is normal. There's no, they're able to open their eyes spontaneously. They're oriented to time, place, and person, okay, and they obey commands. So there's no problem if a person scores 15. Here it also notes that the comatose client, if the patient scores 8 or less, they're likely to be comatose. Okay, and then we'll talk more about that as well. So we do grade them, and they're classified. Head injuries will be classified as mild, moderate, or severe, depending on the score, the cumulative score for the Glasgow Coma scale. These are some. Okay, let's go into a little bit more detail about each of these areas. The first one being eye opening. And here's a review of the points. No response 1, but spontaneous eye opening is a good sign, and they get 4 points. They get the maximum points. So if spontaneous, if patient opens their eyes during the assessment by themselves or by verbal arousal, for instance, the nurse says their name and they open their eyes, then they get a score of 4. If the patient opens their eyes only when commanded to do so, Mr. Smith, would you please open your eyes? Then they get a score of 3. Now, if the patient opens their eyes only to painful stimulation, they get a score of 2. And so this painful stimulation can be elicited through applying pressure to their nail beds. That would be preferable. Or perhaps the supraorbital notch above the eyes, or rubbing the patient's sternum firmly with your knuckles. Even pinching the trapezius muscles up there near the shoulders and neck. Okay, so if the patient has no response, no eye opening, despite eliciting painful, trying to elicit a response with painful stimulation, then they get a score of 1. Okay, so that's how that works. Let's move to the next category, or verbal response. Again, we have a maximum of 5 points. So this person converses, they talk, they're oriented, you don't have to do anything, and you can observe that they get a 5, they're normal, and all the way down to 1, which is no response. So let's interpret that, how we score the Glasgow Coma scale or verbal response. Sometimes this can get tricky in our nursing questions, in the stem of the question. So don't get misled. Make sure that you truly understand how many points they get for each of these responses. All right, so Questions that pertain to ascertaining patients' orientation to time, place, and person should be asked. The nurse can ask questions such as, "Mrs. Smith, where are you?" If the patient says, "I'm in the hospital," then that shows that the patient is oriented and converses, so the patient gets the maximum score of 5. If the same question is asked and the patient answers, "I'm inside a bus," it shows that the patient is disoriented or confused, though it's still in a conversational manner, but the patient scores a 4. If the patient is asked, "What time of day are we?" and the patient gives a response that is completely out of tune, such as, "I won a Visa lottery yesterday," the patient gets a 3 because the answer is inappropriate. It's out of context. And that response is not conversational. It's not related to the question. If the patient makes incomprehensible sounds, such as groaning or moaning, with or without painful stimulation, it does not matter, they get a score of 2. Okay, so in this case, it is the groaning or moaning. They're just sounds, okay? And if there is no verbal response at all, despite painful stimulation, they get a score of 1. Now, this one we need to clarify to make sure that you understand as well. Motor response, again, this time there's 6 available points, and the highest was a person who can obey a command, and that is 6. Okay, and then no response, of course, is 1. So this is where we want to review 2 major concepts. First, we can talk about posturing, okay? When we talk about posturing, we're referring to decorticate and decerebrate posturing. And I have the pictures here, and you will review that, so make sure you understand those 2 different positions or postures that patients can assume as a result of brain injury, okay? And the worst is decerebrate, okay? You pass through decorticate to get to decerebrate. So you get more points for decorticate because it's not as bad as decerebrate, which only gets 2 points. Now, what I need to explain to you is with the points up here with localizing to pain and flexion withdrawal to pain. So there are questions where they like to see if you can distinguish between whether a patient localizes to pain or withdraws from pain. Here is one other slide just to help you remember and to review the characteristics of these different posturings that can occur with our patients. And the decerebrate and decorticate, decerebrate being the worst, this person has problems in the midbrain or pons of the brain stem. Okay, and typically if it's decorticate flexing, it is a problem with the cervical spinal tract or cerebral hemispheres. Okay, so there's a difference there. So let's interpret that motor response. They get the highest score of 6 if the patient moves their hands and legs in response to a command. The nurse may put her hands in a patient's palm and ask the patient to hold her hand tightly. If the patient cannot obey the command, then the nurse has to inflict pain on the patient by a sternal rub or applying pressure on the nail bed, as we said before. If the patient takes his hand directly to the source of the pain and removes the nurse's hand at the site of the painful stimulation, that is a score of 5. It means that the patient is localizing pain. Similarly, if you go to start an IV on this patient, say you're starting an IV in the right AC antecubital area, And if the patient takes his hand, his left hand, and reaches over to the source of pain and tries to move it away, then he gets a score of 5. That's much better. Localizing to pain means that the patient is crossing the midline of their body to the source or site of the painful stimulation. He gets more points than if they have a flexion withdrawal. In this case, the patient pulls the limb away, withdraws from the painful stimulus, and only receives a score of 4. So in this case, I like to give the example if you are, again, starting an IV at the right AC, and instead of reaching over with the left hand to move it away, they simply withdraw their right arm. So he pulls away, causing flexion of the arm away from the site of the painful stimulus. We have not crossed the midline of the patient's body. So that is withdrawal. And sometimes you may not see the word flexion with it, but it is withdrawing from the painful stimulus. And then, of course, we move into the abnormal flexion posturing positions called decortication, or then also called decorticate posturing or decortication. Sometimes they also refer to it as the mummy pose. But what we can describe this abnormal flexion or decortication as the patient's arms are adducted. They're drawn toward the body and they are flexed. The fist is clenched, the wrist is flexed and placed on the chest. Also, the legs are extended and internally rotated, and there is plantar flexion. If a patient demonstrates these features, they get a score of 3, and it indicates that there has been damage to the cerebral cortex. Now, going further, we can have abnormal extension, also referred to as decerebrate posturing or decerebration. Here, if we describe it, the arms are extended, adducted, and pronated. The wrists are flexed and the fixed, clenched, and the wrists are rotated outward. The legs are extended and we have plantar flexion. The teeth are also clenched. These features are signs of severe damage to the brain. There is irritation or excitation of the brain stem or a lesion in the brain stem. So here is an example of an NCLEX style question that you need to interpret and assign a Glasgow Coma scale to this patient. So I'll read it together. A 31-year-old woman received a closed head injury during a motor vehicle crash approximately 6 hours ago. Her CAT scan indicates she has sustained a frontal contractile contusion of moderate severity to the left side of her brain. She's unresponsive to verbal commands, opens her eyes only to pain, withdraws to pain stimulus, and only occasionally makes sounds which are incomprehensible. Her blood pressure is 150/68, heart rate 72, and respirations are 28 breaths per minute, and mildly labored. So let's talk about how we would calculate it. The eye-opening response, this patient, woman, gets a 2 because she has eye-opening to pain. Her verbal response is a 2 because she makes incomprehensible sounds. And she has a motor response score of 4 because she has a motor response to pain. So you should have totaled up a score of 8. And think about what that means for this patient. She might be in a coma or also needing mechanical ventilation and need to be intubated. So here we have that severity of their head injury based on their Glasgow Coma score. It can be classified into 3 groups, from mild, moderate, and severe. The highest score we said was 15. So 13 to 15 means mild head injury. A score of 9 to 12 is moderate head injury. And a score of, remember 3 is the lowest, 3 to 8 is severe head injury. So that previous patient on our example would be classified as having a severe head injury. And commonly, this would suggest a coma, and the patient would be in need of intubation and mechanical ventilation. A score of less than 8 is associated with a poor prognosis. And I want to read some stats to you about moderate head injuries so that you can see how life-changing these injuries are. So after moderate head injuries, 63% of patients remain disabled 1 year after their accident. And after severe injuries, the figure rises to 85%. So that's what we mean by a poor outcome. Surprisingly, minor head injuries also have a poor prognosis, with 79% suffering severe headaches, 59% suffering memory problems, and 34% unemployed 3 months after the injury. Okay. Only 45% of patients who've suffered a minor head injury are fully recovered a year later. This slide was created to make sure that you understand the difference between these two questions here. If you are asked about a patient who's had a head injury, and if they ask you, what is the priority assessment? Yes, the answer will be respiratory status. Of course, I think you know that. But if they would ask you, what is the earliest indication of neurological deterioration? You need to respond by saying changes in level of consciousness. Okay? So those are 2 major things that you should understand and be able to apply, okay? Now, I did say that we would be returning to this concept of Cushing's reflex, sometimes called Cushing's triad, when we talked about increases in intracranial pressure. This is a late sign of an increase in intracranial pressure. This would be really bad news for your patient if they began to demonstrate or display these 3 types of symptoms. Cushing's triad is a physiological nervous system response to increased intracranial pressure. It includes a widening pulse pressure, irregular breathing, and a reduction of the heart rate. We see hypertension, a severe hypertension, and it usually is seen in the terminal stages of acute head injury. So it may indicate imminent brain herniation. Signs and symptoms of increased intracranial pressure in addition to Cushing's triad include headache, vomiting, drowsiness, and lethargy. Okay. Now, cerebral edema is the major cause of reduced blood flow to the brain. And it's also a major contributor to increases in intracranial pressure. Cerebral edema occurs between the first and 18 hours after an injury, and it really peaks at around day 3. It's kind of interesting, although you're not going to be tested on this, but I thought it was very interesting that alcohol actually promotes cerebral edema by increasing the permeability of that blood-brain barrier. So see, if you are drinking and having a car accident, that would also contribute to increases in intracranial pressure and cerebral swelling. Now, cerebral perfusion pressure is the pressure needed to ensure blood flow to the brain. The normal cerebral perfusion pressure is 60 to 100. And it is calculated by taking the mean arterial pressure and subtracting the intracranial pressure. Now, head injury, some of the medications that you're likely to see these patients on, okay? They can be given pain medicines, but we avoid opioids if there is head injury because of the respiratory depressant effects of opioids is going to be avoided. We don't want to depress their central nervous system. Another medication would be dexamethasone, also called Decadron, and its purpose is to reduce swelling. In this case, with head injury, it's to reduce cerebral swelling or edema. Okay. They could also be on methylprednisolone, and that is solumedrol. That's what we call it in the hospital, a solumedrol. It too is going to be used to reduce cerebral edema. And of course, the whole point of reducing cerebral edema with those two medications is to decrease intracranial pressures, right? Now, the one that they love to test you on is what we have a picture of here, and that is mannitol. Mannitol, also called osmotrol, and sometimes simply referred to as a hypertonic solution, because it is a hypertonic solution. And it is truly a monosaccharide that does not cross the blood-brain barrier. So therefore, it elevates the plasma osmolality. And so it is effective in removing fluid from the brain. Its effect is rapid. The onset is within minutes. Unfortunately, the reduction in edema is only temporary, but it does buy time for surgical evacuation. In other words, we can try to keep the intracranial pressure low until the patient can get to surgery and have, for example, a hematoma evacuated. Now, besides having to know that mannitol works through osmotic diuresis to pull fluid out of the cerebral tissues and move it back into the intravascular space. They also want you to know the most common complication of that. The most common complication of osmotic diuresis is dehydration. Okay? So then you need to think about what are the signs and symptoms of dehydration. Things like dry mouth, rapid pulse, We talked about tachycardia, dizziness, and faintness. Okay, so we always have to be thinking when we administer medications, what could be a complication and what would be the signs and symptoms of that complication. Continuing on in the same vein, we're going to talk about medications for our head injury patient. Another classification of medications are neuromuscular blocking agents and also sedatives, because they go together. Neuromuscular blocking agents is another classification of medications that you should have some understanding of, and they are abbreviated NMBA. And they will paralyze the patient's muscles, skeletal muscles. Okay, they're neuromuscular blocking agents. Sometimes that's necessary to manage agitation in our head injury patients. Okay, certainly it's not an action that we take lightly, but it may be necessary to manage their agitation, their behavior after head injury. At the same time, this person may also be taking sedatives, and that is an issue because it can mask changes in level of consciousness. So remember that when you give a patient sedatives who's had a head injury and you want to assess their neurostatus, that's going to be a problem. Okay, so sedatives can mask changes in level of consciousness that you are trying to assess. Then there's also pentobarbital. This is a barbiturate. Sometimes it's needed to induce a coma in our head injury patients. This also decreases metabolic demands of the brain. So by decreasing cerebral metabolic demands, the brain doesn't need as much oxygen. And so this can help to decrease secondary injury. And finally, we have another classification, and that is our anti-seizure medications. They can be used to treat seizures if they develop or to prevent them. So phenytoin is a classic anti-seizure medication. Phenytoin is also called Dilantin. I'm going to continue this second portion of this presentation on another video. I think that this one has been long enough, so we're just going to continue from slide 18 to the end of the presentation with another video. See you there.